otherwise, we will get started. So I am Jenny Honeycutt. I'm our Assistant Director for Research Engagement and Educational Programming at the Ptsd Veteran Center. And this is our research chat series, which is part of the Military Service Knowledge Collaborative, which is our research arm of the Ptsd Veteran Center. So the purpose of these chats is to disseminate research with veterans back into veteran communities and offer an opportunity for various stakeholders to engage with us in conversations and dialogue around certain topic areas that are pertinent and relevant to veteran communities. So today we have Dr. Julie Bobbitt, who was previously a faculty member here at the University of Illinois Urbana-Champaign, but recently moved over to the College of Medicine at the University of Illinois at Chicago. Still doing fabulous work with veterans in the cannabis space. So she is here with members of her research team to talk with us today about older veterans and cannabis use. Quick disclaimer, this is being recorded and will be available on our Ptsd Veteran Center YouTube channel and our website after the presentation today. So Julie, I don't know if it's up to you if you want to take questions throughout or kind of wait till the end, but I will just turn it over to you from here.
I'm happy in either way, as long as I won't be able to see them. So if you see something come through the chat, you want to stop me, if somebody can monitor that, that would be great. And I'd be happy to answer as we go along. So
perfect. I will monitor the chat.
Perfect. Thank you. And good afternoon, everyone. Thanks so much for inviting me to present about our research. And I really appreciate you joining today. Before I get too far into this, I really want to say this is very much a team effort here, and you guys might recognize some of these names, but I just wanted to, Kelly is on actually on the presentation today. She's here. Jung Kang is with the Department of Kinesiology and Community Health in the College of Applied Health Sciences. Kelly was with social work, and she is now down at Texas State, so Dr. Kelly Clary. And then Laura Quintero is a PhD student in the Department of Kinesiology and Community Health, and she has also worked pretty closely on this project with us. So I just want to make sure I brought recognition to them. Okay, and real briefly today, I'm going to start by providing you just a little bit of background about myself, explain the research background that kind of led us in this direction, talk about the Illinois Medical Cannabis Project, and then talk about our MSKC project, which is currently happening, and then just give you a little idea of what we have in mind for where we might want to go with this work next. I think the most important thing on this slide is that I'm alumni of the UIUC. So I got my PhD at University of Illinois Urbana-Champaign, and I was primarily interested in, and still am, chronic disease management for older adults. And following that, I also participated in the Health and Aging Policy Fellowship, which is part of the Congressional Fellowship Program. And I was in the Office of the Surgeon General. And that comes into play because it's really what inspired this focus on this particular research. And I'll talk about that next. So while I was at the Office of the Surgeon General, I mentioned that, my research interest has been in chronic disease management, and then I had that policy interest. Dr. Vivek Murthy, who is actually coming back, was just then doing the Turn the Tide campaign. And for those of you who might not be familiar with that, that is specifically his campaign to address the opioid epidemic at the time. And while I was out there, so I was involved in learning a lot about that campaign. And then Congress actually held two hearings during that time on opioids. One was the Finance Committee and the other was the Special Committee on Aging. But both of them discussed also cannabis. Like, should we be considering cannabis in the space of opioids? So that really sparked my interest. And I started talking to a colleague at the University of Iowa. You saw on the last slide that I have some roots at the University of Iowa and their Center on Aging. And so we started doing some pilot groups just to look at older adults, non-users and cannabis users in 8 states, just to find out what's going on, because we knew the numbers were getting higher. We just weren't sure what was taking place. And so we also fielded this, first time survey with that group just to see how they, what questions they found useful or difficult. And then we were able to go to Colorado and use that survey and collect some information. We repeated that same study in Colorado with funding from the Retirement Research Foundation here in Illinois. And that's what kind of led us, I'll show you this next slide here. Well, actually, in one more slide. First of all, that's what led us to our current research. But I wanted to say, why should we be concerned about the use of cannabis by older adults? And I already kind of alluded, the numbers are really high across the states who are legalizing. When we started looking into it, many of the programs we saw were seeing really large increases in the 60 and older population, actually 50 and older population. When we asked the Illinois Department of Public Health several years ago to run their numbers for us, 51% of their program were over the age of 60. And so that surprised us. We knew the numbers were growing, but that surprised us in that program. Second, also because during our research, some of that preliminary research that we were doing, and then other researchers are seeing, only about 30 to 40% of older adults are actually getting advice about cannabis from their physician. So only 30 to 40% who, they're saying they're using for these medical purposes, but they're really only going to their care provider. So who's giving them information about what to, how to use cannabis and also how to avoid negative outcomes. So, maybe there's an opportunity to influence a little bit of education there. And then finally, opioids, kind of bringing it back to that opioids. It's a problem nationwide, but it's really a deeper concern for older adults as well, who have multiple chronic conditions, more likely to be using multiple medications. And as they get older, they're not, their metabolism isn't metabolizing those medications as easily. So there's just more complications and side effects relative to those types of medications. So is or could cannabis be a viable pain control option? We don't know, especially for naive users. We have a lot of people who just started using cannabis. So those are the kinds of things that we were thinking of and what are really important and specific to older adults. So back to the Retirement Research Foundation. This is some of the information that came out of that study. We did both surveys and focus group. We did 30 focus groups in the state. And the top bullets are mainly a concern for everybody. But the bottom one is what turned our attention. So when we were doing these focus groups, two of them for sure, we had a lot of veterans who were attending, which we didn't know at first. We didn't think about this. But two of our focus groups were almost primarily all veterans. So that made me think, okay, maybe there's something going on here. They had similar thoughts to the 4 bullets as far as, they stated now they were using for medical reasons. There wasn't a lot of education out there. They were having positive outcomes relative to pain and sleep. But that opioid issue was coming up as well. But also, veterans, many had started using as a result of their time in the military, which was interesting to us. And many had complex physical and mental health concerns. So what I did to kind of illustrate what we heard from those 2 focus groups, I didn't pull the other focus groups, even though there were some veterans in those. These are full, like almost completely veterans who attended these 2 focus groups. So I pulled some quotes and wanted to bring to attention some of the specific concerns. One of them being that federal laws governing the VA. So individuals who might want to be in a medical cannabis program or even consider cannabis really can't do so through the VA because it's federally considered an illegal substance. So there's this disconnect there. Either they're not telling their physicians about it, they're going about it, maybe a different way, or going to a not the regular care provider. But also there's a little bit of a fear that they might also, if you see the second bullet from the bottom, that they might actually get dumped. That's what they said from the VA, or maybe their medications might be taken away. But there's just this overall a little bit of fear of the federal level, a little bit of not wanting to discuss it, or physicians just not being allowed to discuss it with them. And of course, regardless of regardless if you think that cannabis is something that a person should use or not, it's really important that that physician and patient have that communication, again, because of the other medications that they might be taking. This really is something that needs to be discussed, or at least known. So here's the second focus group. And again, we start off with the state versus federal law, but you see the first bullet there, that's an example of someone who got removed off of their current medication because they tested positive for being in the program. And so what this person is saying is that Ambien was working really well for me. They took it away because I tested positive for marijuana, but I had given up opioids, but that didn't matter. And then the next two I put in here because I just, we talked about opioids, and opioids are primarily, pain, but I really wanted to bring to attention also that sleep and tranquilizers and those and anxiety, depression, that's going to become a theme here that you're going to see as well. So S11, you can see that they, didn't want to try it. They didn't think that that was something they want to do. They definitely didn't want to smoke it. But after they realized there were some other options, they cut their pain pills in half and they've gone without sleeping pills, and their quality of life seems to be better. And then this last slide here, again, now starting to talk about PTSD and chronic pain. And they tried it. It was the first time I ever slept through the night. And then the last one, again, anxious, using Xanax, but found out that they could use cannabis without having the side effects of using the Xanax. So those are just some of the things that we were seeing and that made us think, this would be interesting to look into. And we really had the opportunity to explore it further because right as we were going through those focus groups, we were also working with the Illinois Department of Public Health on a contract to send out surveys to individuals who were over 60. So the medical cannabis program is for the state of Illinois, is run through the Illinois Department of Public Health. When we did this survey, they did not have recreational available here in the state. So I just want to say that. So let's see, moving on. So the original goals really were to look at motives, patterns, and outcomes of cannabis use for people who are 60 and older. And we also wanted to look at the program itself. The state was interested in hearing some feedback about the program. I'm not going to talk too much about that. But luckily we were going through those focus groups right about the same time that we were doing the survey, which included this kind of information. Like I said, patterns of use, attitudes, motivation, self-reported health status. So we asked them conditions for what they were using cannabis for. We also asked them pain related, or I'm sorry, symptoms, including pain and sleep. I'll show you that in a minute. But right here is what our overall survey looks like. We had 4,066 people respond, or actually surveys that we could work with. Average age being 67, and about 50-50 split between male and female. And you're going to see that change when we pull out the veteran specific data, of course. So here are the questions that we added to just pull out to find. I mean, we were interested in all of that information, but then we also wanted to be able to pull a subgroup of individuals who had who were veterans. And we worked with individuals, Jenny from the Ches Veterans Center, to make sure that we were asking the questions correctly. And these are the questions that we added. So we were looking for whether they served previously in the US military, reserves, or National Guard. We also wanted to know, we were specifically looking for individuals who might have served in the Vietnam War, because that's a lot of the individuals who were showing up at our focus groups. And then also if anybody had been deployed to a military conflict. So, okay. And so the results that I'm going to show you in the next several slides are from that original survey. Of those, of the 4,066, we pulled out a group of 593 veterans who responded to the survey. 92% were male. So remember earlier we had a 50-50 split, but it was weighted very heavily because of our veterans who were in there. So there were 90% male, primarily white, which was the same across both groups. And the mean age was closer to 70. So just a little bit older as well. So compared to the non-veterans in our study, our veterans were older, a little more diverse, even though we had very little diversity in our subjects, and significantly more male. And if you take out, we saw that 50-50, but if you take out the veterans and compare them to non-veterans, it was actually 41% non-veteran males. So that was not surprising to us about the veterans, a little surprising to us about the non-veterans, because if you look at research, statistics, marijuana use seems to be higher in males. So overall, not older. So that's something to think about as well. Let's see. Okay, so just a little bit more about the different demographics. Nearly 40% of veterans in our study had a college degree. Most were retired. Most reported being financially insecure, and compared to non-veterans in our study who had higher education, more likely to be employed and report more financial security. Now, part of that could be because, remember, our whole group was a little bit younger. So, and our veterans were slightly older. So it really could be that our veterans are more likely to be retired and living on fixed incomes. So just wanted to point that out. In Illinois, you have to have a qualifying condition in order to obtain a certification from a licensed physician. Now, this differs just a little bit for veterans. You still have to have the qualifying condition, but in the state of Illinois now, veterans do not have to have a certifying physician because of the federal, what we were talking about with the VA and the federal guidelines. So what the state of Illinois requires is that the veteran get their own health records, and they can apply to the program directly without needing to go through a physician. So that's a little bit different. But as far as the qualifying conditions go, there's a long list of them, and we did include a long list to make it easy so you could actually see this. I pulled out some that were the most prominent, and cancer and PTSD, where you can see were the highest. Now, people could have more than one condition that they report. So just wanted to point that this is just showing you the raw data. So what's interesting, PTSD is not commonly reported for our non-veterans. It's there, but not to the extent that this was. So I wanted to point that out. We weren't, we knew that we were going to see PTSD. There's been a lot of research on PTSD and cannabis. I'll talk about that a little bit later. But we really weren't expecting it to be a higher reason. People were more likely to use for PTSD or other emotional problems than they were for pain related conditions. So that was a little interesting to us. Let's see. Okay. All right. And then I mentioned that we also asked about symptoms. So kind of going back to pain clearly still is a big deal, but sleep and emotional next to that are the next two. And again, they could choose more than one on here. If you were to look at this compared to our non-veterans, sleep is still a big deal. Pain and sleep are the two most reported reasons for older adults to use cannabis, but it's higher. Sleep is higher for veterans and non-veterans here, and the same for emotional problems. So for qualifying conditions, we had PTSD, but for symptoms, we had emotional, which included anxiety, depression, and insomnia. And then digestive problems included nausea, lack of appetite, or constipation. So let's see. All right, and then just to give you an overall idea, based on other previous research, we knew, like I said, older adults would be using more for pain and sleep. There's actually a National Academies report, a 2017 report on the health effects of cannabis and cannabinoids, and it's found cannabis to be effective in relieving chronic pain and helping with sleep. So there's scientific evidence, actually enough research now starting to become available to show those two things. So not really a huge surprise, like I said, but just higher in those two areas. And then this little other category, we did give respondents an opportunity to write in if they had other concerns, but there wasn't any like theme, like any strong one. Actually, muscle spasticity or leg cramps, a lot of comments came back from that. Okay, we also asked about health in the past 30 days, and you're going to see these outcomes, and then I'm going to show you how they feel cannabis had an impact on these types of things. So overall, the pain score we asked on a scale of 0 to 10, with 0 being no pain, 10 being the worst possible imaginable. And we average is 5. We asked how often they experienced emotional problems, and we gave the scale of never to almost always. And we asked them to rate their sleep quality also on a scale of poor to excellent. So pain levels were not as high as we might have expected. Again, when we went into this, we had, our background research that we had done indicated, the pain, sleep, PTSD were concerns of veterans. So we thought that that might be higher, but also it could be that they're already using cannabis or even other medications to control their pain. So maybe the pain that they're reporting is because they're already using some other things. And about a quarter of the respondents reported experience emotional problems, often or almost always, with the majority reporting sometimes or rarely. And then sleep quality was fair to good, which also was a little surprising because we knew that pain and sleep on the other slide were the primary reasons they were using cannabis. Same could be true though. They might be using cannabis and their sleep might in the last 30 days might be good. So how we could have fixed this would have been if we could have done a nice before they started the cannabis program study and then after, but we weren't able to do that. So a couple more health indicators we asked about. Overall, veterans reported good quality of life, with nearly 70% reporting good to excellent and only 5% reporting poor. And psychological well-being rated higher, which was interesting again, because we had so many veterans report using cannabis for mental health conditions. Let's see. Again, that could be a similar situation to the other two, right? Using cannabis is helping the situation or other medications. All right, so here we get to the cannabis, opioids, and benzodiazepines question. So as mentioned at the beginning of the presentation, opioids is really something we're interested in. We're starting to see this relationship between opioids, cannabis, and pain. And many of our older adults and even our veterans in our previous study talked about cannabis use in relationship to other medications. So we asked about past year opioid use. We asked about past year use of benzodiazepines. So about 40% of our veteran respondents reporting also using opioids, and 17% reported using benzodiazepines. So that's pretty similar. Actually, you're going to see a slide later. So keep those statistics in mind, because when we do the subsample, you're going to see it's pretty close to that as well. The really interesting thing that when we did this paper is that veterans in our study were less likely to be using opioids or benzodiazepines than our non-veterans. And again, we didn't expect that because we were expecting complex medical problems might call for higher use of those, but it wasn't. However, they were using cannabis more frequently. So you can see nearly 60% of our veterans were using daily, another 25% were using 3 or more times per week. So this could be a substitution effect. We could see lower use of these two medications and higher use or higher frequency of cannabis use. I'll talk about that in a little bit too. It could be due to the VA prescribing practices, because the VA has made a really concentrated effort over the past several years to lower prescribing of both opioids and benzodiazepines. So maybe veterans in our study are receiving fewer prescriptions for that. So unfortunately, with this study, we weren't able to distinguish between veterans who were being seen just in the VA and those who might be seen by community providers. So you'll see that we try to look at that in our next study here. Because we were really interested in learning about why people were using cannabis relative to their other medications, we asked respondents to indicate why they were choosing cannabis and gave them following options as well. So I mean, we asked them a lot of other questions about cannabis use, but we also asked this specifically, and we gave them options. They could answer more than one, but we said prescribed medications don't work. They don't want to take their medications at all. They don't want to have to do them, or they don't want to take them more than necessary. We did put something in there about a provider that said cannabis would help. And then we wanted to capture a little bit about non-medication related therapies and whether they helped or not. So you can see they had an opportunity list, like I said, more than one, but you'll see that, about 50% felt that their prescribed medications didn't work. A combined nearly 75% said they didn't want to take medications or didn't want to take them any more than necessary. And so there was this connection between cannabis use and prescription medications that we wanted to look more into. And then this is the health, this is what I mentioned, the health outcomes relative to their cannabis use. So we asked veterans if cannabis use made their outcomes worse, had no change, or made it better. So I listed quality of life, pain and sleep quality, and ability to manage health up there, just so you can see that, the majority reported that cannabis use made these outcomes better. Now, these are more positive health outcomes, and we would probably anticipate that based on what we were seeing. We did ask about memory, falls, ER use, but the percentage was so small that I didn't put that up here. We are trying to look, though, into small subgroups of people who are having negative outcomes, and just to see if they're, maybe related to multiple chronic conditions, or maybe related to lifetime use versus new use, or the type of use, smoking versus edibles. There's a big concern about edibles. So we are trying to look at that a little bit, but overall you can see majority reported cannabis use made things better, or no change. There are very, very few that reported made it worse. Now, let's talk about the bias that could be there. I mean, these are people who are already in a medical cannabis program, and so they might already have a good thoughts about medical cannabis, right? We're definitely not capturing the people who had a bad experience and stopped their participation in the program. So there is definitely that bias there. So we want to look a little bit more into negative outcomes in our next study as well. So really, we did some preliminary work that, can help a little bit in looking at maybe why, providers should start having these conversations or open this communication a little bit, that might help inform even back to the state policies that they have. But we didn't learn enough. We need to know the extent to which veterans are substituting or co-using. We don't know if what we're seeing happens over time. We see this as cross-sectional one time. They're reporting good things, but what happens if they get another condition, or their condition worsens, or the pain worsens? Do they stop using cannabis? Do they start using opioids again if they were using this as a substitute? Or maybe long-term, are there more instances of falls, memory problems, or even the need for substance use disorder treatment? So enter MSKC, which provided us with some funding to conduct a follow-up study. So the really nice thing about the MCPP study is that we asked individuals, because it was completely blind. We didn't know who was filling out our survey. We weren't given the list. The IDPH sent it out for us, and then people responded back to us. So if they wanted to self-identify and follow up in another study, they could do so by providing their email to us. And so what we wanted to do is have this follow-up study where we could do another survey, and then also interview and get that a little bit deeper knowledge about, what is going on. So so this is what we did. We had about 220 people provide us their emails from that 590 or 93 from the almost 600 people. And we sent surveys out to all of them, and we received 120 responses. And we are currently just wrapping up interviewing the 30 veterans. And Kelly is on the phone or on the call here, and she can she's been interviewing along with me. So we've been doing a lot of phone calls, but it's been really great having the opportunity to talk one-on-one with veterans, and not in a focus group setting either. It's been really good. So I wanted to show the changes that we put on the survey to start collecting some of the information that we didn't have before. We didn't ask before the branch of the military service, so we added that. We did not know much about how cannabis was being used other than how frequent it was. So this time we added some more questions. Do they know the dose that they're taking? Do the THC level, the CBD level, sativa indica? Like, we asked a lot more questions about their cannabis use. And we asked more than just, have you used opioids or benzodiazepines in the past year? We also asked, how has that changed relative to your cannabis use? And we asked people to describe that so we can get some very specific instances, understanding more about what is going on there. And then we added outcomes. Remember, I mentioned we had a few negative outcomes in there. We thought we should add more. We added outcomes relative to driving. Have you experienced any type of citation or driving while under the influence related to cannabis? Has cannabis use created any problems with your current relationships? And then we did ask that question about, have you needed to seek treatment for substance use disorder? Okay, and so like I said, this study is going on right now, so I don't have a lot of the data to share with you, but I can show you what it's starting to look like. So you can see 91% male, 91% white. The two probably most interesting at the bottom, 99% have had active duty and 33% experienced combat. And then a little over half of our sample, we ask if they're using in the past year, and then we ask, are you using for medical purposes only, or are you using for medical and recreational use? And are you using for recreational use only? So you can see 54% were using for medical purposes only, and about 41% were using for both medical and recreational together, and only at like 4%, I think, if you add that up, was we're using just for recreational only. We pulled those out of our data when we do this. And then 4 people had dropped out or weren't using cannabis in the past year. And we actually interviewed, I think, 1 or maybe 2 of those. A little over 50% are being seen by the VA either by themselves or with the VA and community. So we're going to be able to look at that data and see if there's a difference. 43, almost 44% were community provider only. So that was interesting. I wanted to also include, I don't have this on the table, but I think this is important. Remember, we were talking about tapering and the fear and those focus groups of people, having their drugs taken away from them if the VA found out that they were using cannabis. Only 4 people reported having their medications tapered due to their cannabis use. Now, this is a really small sample, but I just wanted to follow up with that because we did ask that question. And you can see here nearly 40%, almost exactly, from that 600 group are using opioids, and only about 14% are using benzodiazepines. And I think that in the 600, we had about 17%. So we have a nice representative, small sample of that larger group. I shared with you a little bit more of the conditions this time, so spread out a little bit more, and you can see the reasons why veterans are reporting. Again, that PTSD being very high compared to a lot of the others. And you see we have a huge other column. That's because there's a lot of other smaller other things in there that they might have written in that maybe could fit underneath some of these things, but I just combined those together. So still PTSD stands out there a lot. The other thing I wanted to point out is originally when we started, when the medical cannabis program was started, it only allowed for rheumatoid arthritis, but it expanded to add osteoarthritis. And I just wanted to point that out, kind of the 1, 2, 3, 6th bar over, because we're seeing a lot of people who are who have osteoarthritis who are starting to use cannabis now that that's been added. Okay, so the survey comments I put in here because we gave them an opportunity to write in some comments. And since I can't share with you right now, the transcripts were just transcribing those interviews, I can show you some of the comments that we're seeing, both good and bad. I think the biggest, let's see, some are about the kind of cannabis people try. So there is definitely this big interest from a group of people who are not smokers, who don't want anything to do with that. You saw that in our other focus groups, but you'll see that in some of these comments as well. But also a little bit of that worry about edibles too. So here, let's see, about 4 bullets down. I don't have, nor have I smoked any cannabis. I tried edibles, I didn't like it, but there's this ointment that I've tried that is helping me. So I wanted to kind of show people aren't just, this isn't a program where people are just smoking. Sometimes there's creams and ointments and other things that work for people. Another thing that came up, and I don't think, Kelly, you might have heard this one time, but I've heard it from a few of my interviews, and then this was written in here too. I never thought about the allergy aspect, but there are some people who can't use aspirin or anti-inflammatories, and so the pain relief that they can get is kind of limited, or and opioids might bother them. So this is also a pain relief option for those individuals. The second bullet I think is interesting. That goes to the prescribing. The VA quit opiates. They didn't completely quit them, but for this particular individual must have been taken off of them. That's the only reason they turned to cannabis. So maybe they wouldn't have preferred cannabis to that. Let's see. And the bottom two, I think, are really interesting. And these are the stories that we were looking for. If they could give us more specific information on how cannabis was having an impact on their medication use. So this individual was using OxyContin plus taking 10 to 12 Tylenol, just decided that it was too much one day. And their doctor actually worked with them. So this is a community provider. And now he, is only taking a couple of Tylenol at night before bed. So that will be a person that will be interesting to see if that, when we can look longitudinally at that data, if that continued. And then the last one, and I know I'm getting a little bit long on time. The last one here, I think is really interesting because stereotypically, we hear a little bit about cannabis and couch potatoes and people not wanting to be very active. And I would just like to say for this particular age group, I'm not talking about everyone, for the older adult, we are finding just the opposite. We have heard story after story, not just from veterans, about cannabis allowing them to be able to do the things that they want to do, like golf, play piano, go to bridge club, exercise again. It's really interesting and how opioids made it a little bit more difficult for them to do that because it made them fuzzy, or like they felt like they were in a fishbowl, or were not able to engage as well. So that's been something different. And there's actually a study that just came out of Colorado that found the same thing about exercise in older adults. So I think that was kind of an interesting thing to look at. So there we are. We have in the future, we obviously, the purpose of this funding is to take what we're doing in this pilot study and look for future funding. And we really want to do a much more nationally representative survey. And we want to gather more information about maybe non-conventional health modalities that people are trying, not just cannabis, but other alternatives as well. We have, thanks to our working with the Ptsd Veteran Center and with Jenny Honeycutt, we have been able to, we have a couple of advisory people who we meet with every few months who are veterans themselves and very involved in some national groups. And they have connections to these organizations on here who would really help us if we could find, the right funding source and the right collaboration. So that's what we're considering. And with that, I wanted to still give a few minutes for questions if anybody has any. I'm going to open this back up so I can see people.
Thank you so much for that, Julie. It's so interesting. There's so many, I think, things to be talked about and hashed out with this topic and just all of the data. I have notes and questions, but I know one of them in the chat box. I don't know if you look specifically at, was there a decrease in drinking with veterans when they started using cannabis, or if you looked at any other type of substances that were not prescription medications?
Not in this study, we didn't. That's a good one though, because a lot of our conversations that we hear are, well, it's no different than alcohol. I could be going out and drinking a bunch of alcohol, but I don't do that anymore. I find that this relaxes me, this is better, and I don't go out and start a fight. And Kelly, Kelly, please chime in here because you've been interviewing so many people as well. I think that you could, add at any point if you would like to. So. But I think that's I think that if we could do a bigger study to finish up that thought, we would like to include more and different types of behaviors.
Hello, Julie.
Hi.
That's Reggie. Good.
Reggie, hi, how are you?
Fine. My question more is about the politics of all of this. As you stated, it's legal in 34 states. A lot of the American territories, Guam, Puerto Rico, Virgin Islands. It's been endorsed by expert groups like the American Nurse Association, American Public Health Association.
Yep. Veterans groups.
Officer physicians. And most veterans support it, but yet it's not used in any VA facilities, of course, because it's illegal federally. But how close are you working with some of the activist groups around the country to spread the gospel and to persuade the federal government to get on board?
Yeah, that's a really good question, Reggie, and it's a really good point. There is, well, to answer your question, Michael Krawitz is somebody that Jenny and I have been working with, and on that, let me see if I can go back a slide there. He is with Veterans for Medical Cannabis Access. So he is someone who broadly is working, internationally working to advance medical cannabis for veterans. And so he, not that we have had like a huge impact on that, but we're certainly one of the reasons why we're doing this is to provide this information so that he can also take that to, his groups as well. And Jenny, you can comment on that as well if you'd like to, but I know, really at the federal level, a lot of legislation has gone through promoting it. It's promoting, especially for veterans. So it's just a matter of getting Congress to just get passed. And maybe the new administration might have more luck that way. I do know, since we started interviewing, just, for the last several years, I feel like there's already a change in how physicians are. And I even, without calling out anybody, I do know even some of the VA physicians are at least having a little bit of conversation about it, even though they can't have any connection to it. So I think we're moving in the right direction.
Yeah, and I do know that the VA, we were just sort of had a conversation with the director of psychiatric research at a VA in Chicago a couple of weeks ago that was specifically asking about researchers that do cannabis research. So I think it's on the horizon more. I almost feel like from a national perspective, all of the advocacy, all of the Michaels in the world that are really pushing at different levels, like Julie said, he's working with the World Health Organization at sort of the international level. But I think as more grassroots, advocacy, activism is really helping push this forward, I think the federal government is having to at least sort of nod to it and acknowledge it a bit at this point. But I know, Julie, you could speak more to, but just the challenges around funding, getting this type of work funded, even getting it published. There's definitely, I think, a lot of stigma still circulating around cannabis use in general and hesitancy around, looking into, possible positive, medicinal, outcomes and effects of it. So I think that the needle is slowly, inching and moving, but it's been a long time, and I'm sure there's still a lot more work to do.
Yeah, absolutely. It is hard. It's a touchy subject because there is substance use disorder connected to it. There is, life, for youth, there's certainly different concerns than maybe for an older population. For lifetime users, there's definitely a different concern. But if you talk to my 70, 75-year-old who just started trying it for the first time and is having good benefits. They're not worried about the long-term effects of it. They're happy to be engaging in life and really happy with it. But I will say, back to the policy though, Reggie, I mean, even in the state of Illinois, when qualifying conditions first came out, PTSD wasn't even on there. Thanks to Vets Prevail, they pushed to get PTSD added. And then now look at the state is making these pathways to allow veterans to get into the program without needing that certifying physician. So I think we've come a long way just at the state level too.
That's true. I think your research and helps tremendously. The work that you're doing as well as other scholars. So please continue.
Thank you. Thanks for the support from MSKC, right, to let us do this. It's been great.
Yeah.
So we are kind of right at time. There's several more questions in here. I think maybe we could do, if you've got time, Julie, maybe one or two more questions. We extend a little bit. Okay. Can you see the chat box? I don't know if there's one that sticks out to you that you really want to answer.
I can. Let's see. Now I can.
Okay.
All right.
So we've got some questions around.
Oh, really good question. Affordability, and I meant to talk about that, and Kelly could also talk about that here. It is limiting access. That's a very good question, Jules. To what extent is affordability limiting access? And that is a big issue across a lot of the interviews that I have heard. Because people are on, and this is older adults in general, but veterans brought this up a lot. They're on fixed incomes. The cannabis program is expensive, even though there's a medical component of it that's less expensive. Even some of the dispensaries offer veterans a little bit more of a discount as well. But I had people, when we were talking about the 4 people who dropped out of the program, at least 2 of them did so because they couldn't afford it, not because they didn't want to use it, but they just can't afford it. And it's so much easier to go get your opioids and your copay and have that, taken care of. So that's a good question.
What is the cost? I mean, how much does it cost?
Yeah, I have no idea, other than I have heard that it's really expensive. And I've also heard that it's really expensive relative to other states as well. Other like Oregon, Colorado, places that have had it for a while. So that's something, that we can report back to the state. And I don't know if there's something they could do specifically for certain populations, maybe over time, but that is a big concern.
My understanding is one of the rises for heroin was because of access to opioids, and the heroin was actually cheaper.
Yes.
And so where I was going with this question wasn't in that direction, but maybe something like alcohol abuse, and maybe an unintended consequence is if individuals can't get access, they've felt some relief, but now can't get access or can't afford it because they're using the chronic rate. This is then lead to alternative sources like alcohol.
All right. Yeah. Great question.
We had a couple questions about sleep. So maybe if you want to answer one question about sleep, and then we will wrap it up.
Yeah, let's see. I can't answer the one about how much sleep did they actually gain because we didn't measure it, unfortunately. But I do have some interest in a clinical study on that. That would be interesting because I've also heard that over time, maybe that effect goes away, but I haven't heard that from my interviews.
Mm-hmm.
And what is that the other question about sleep, Jenny? What else did you see that?
Well, there's one more, maybe we'll just finish with this one. So this is from Amy. I'm asking about databases for academics to have access to information, I guess related to the cannabis culture or Amy, am I phrasing that question right? Kind of getting at, I think this is probably speaking to, researchers really having access to.
Yeah, it's hard.
Yeah.
It's very, very hard to get data. And there's a few different reasons why. One, because it's state run. So mostly but by public health departments, and they're really protective. So that's part of it. Is in Canada, you can go to, it's not Tilray, but Tilray was one of the big producers, but there's another one, and they have a huge database across the whole entire country. But we don't do that here because federally we're not supporting that or collecting that. So I think that's one of the things. The other thing is just, it took us 2 years to get a relationship with the Illinois Department of Public Health enough to have them put the survey out for us. We couldn't have access to their data. So I think they're getting to the point where maybe de-identified, they're a little bit more open to that. I've noticed, I had somebody contact me who's working with them now who might get some de-identified data, but it's difficult.
Yeah. Which is where I think a lot of these advocacy groups can make a difference. So,
Yep.
Being able to partner with groups like Veterans Prevail and Veterans for Medical Cannabis Access, some of these on the ground grassroots organizations are like entry points, I think, into being able to at least talk with and get data from, people that are engaging with, veterans that are engaging with medical cannabis and that are really in these spaces. So, yeah.
I agree.
All right. Well, we are right at time, a little bit over. So thank you so much, Julie. This is just such incredible and important work. We will have the recording of today's talk available on our YouTube and our website in the next week. We host a new talk every month, so be on the lookout for our upcoming one. I think our next one is focused on children of veterans, children that have disabilities, developmental disabilities specifically. So thanks again, everybody, and enjoy the rest of your day.
Take care.
Nice seeing some faces that I recognize too. Bye, guys.